Hello, everybody. My name is Natalia Rost, and I hail to you from Boston. And it is my great pleasure to join you today to talk about the future of stroke. And I'd like to begin by thanking the organizers of this symposium, particularly Dr. Wolpe of the Houston Methodist Neurological Institute and Dr. Gadia, my colleague in vascular neurology, for allowing me to present my version of the future of stroke, which I believe is in scientific discovery. And I hope I'll be able to convince you of that over the course of the presentation. My disclosures are largely related to the NIH funding. So Discovery is a new NIH-funded nationwide network of 30 US clinical performance sites and 4 cores, which has a common objective to address determinants and mechanisms of post-stroke cognitive impairment and dementia and functional outcome. I'm pleased to report that the Houston Methodist Hospital is part of the participating network chain and will be an important contributor to our highest level of research procedures in this project. And I'm so glad to have so many great collaborators joining us on this quest that is larger than a single objective by a single institution or a single grant ever written. This is just to give you a representation of a nationwide distribution of our network and truly reflecting the expertise and experience of the sites joining us across the US in contributing patients with acute ischemic stroke, intracranial hemorrhage, as well as aneurysmal subarachnoid hemorrhage. Discovery is a fast-moving study. We were fortunate enough to have our first face-to-face investigator meeting in February of last year in LA prior to the International Stroke Conference. Unfortunately, just like everybody else in the research domain, our activities have been disrupted by pandemic, but not interrupted. We have continued to work remotely with a fervor and a necessary level of enthusiasm to get the infrastructure of the study planned and executed. And we had a kickoff meeting in November of last year. We were hoping to be able to enroll our first patient in December. However, as you know, the new wave of the coronavirus pandemic has significantly disrupted the operations of many of the centers that are part of our network. But we are pushing ahead, and we're hoping to be able to start bringing the science of discovery to you as a community in order to advance our understanding and our standing in treatment, diagnosis, recovery, and prevention. And where is the future of recovery that we have experienced over the past century? As you know, the true modern science of stroke, so to speak, had begun in the 50s with the work that C. Miller Fisher, proudly hailing from the Massachusetts General Hospital, and prior to that, from the Montreal General Hospital, has laid in understanding of the diagnosis of the different stroke subtypes, identifying pathophysiology, and then developing the first original personalized treatment approaches. As you know, C. Miller Fisher was instrumental in developing neuropathological understanding of what carotid disease and its contribution to stroke was, as well as atrial fibrillation. He was also perhaps one of the earliest adapters of use of anticoagulation in treatment of acute ischemic stroke, as well as someone who truly believed in approaching each patient with a degree of attention and precision necessary to understand their particular diagnosis, to describe it, and then to treat it with the necessary and available means. And then the next big milestone in the timeline of the developing therapies, for example, was the decade of brain in 1995, to which I refer as the era of IVTPA, really. And it took us probably longer than we should have taken over the course of this era of TPA or thrombolysis, but we have arrived to a universal agreement on the benefit of IVTPA, and we now hold our comprehensive stroke centers, primary stroke centers. We hold the standards for administering this type of treatments. However, we knew that the thrombolysis alone was not enough. Too many patients were not qualifying for it, and too many patients were not able to receive the benefits of that. And so next large milestone that I've been highlighting in this trajectory is really our arrival on the benefits of the mechanical thrombectomy with endovascular therapy applications in 2015, and the manifestation of that being the publications of a number of trials that showed the benefits. And we've really done well in this area. We really have pushed over the course of 20 years between 95 and 2015 the concept of reperfusion. And the question always remains in the mind of a scientist is what's next? We know the realities of clinical trial performances versus practice applications. We know where the standards begin to bend and how patients may not necessarily benefit again in the categories that were not scientifically proven. We often defer to the simple mechanical solutions for complex biological problems without understanding the true mechanisms behind that. And it feels sometimes that advances in science are really incremented with a low novelty. We all know that reperfusion is effective, but often not available to majority of stroke patients. Think about the small vessel stroke patients and patients with non-occlusive large vessel disease that are not able to benefit from reperfusion at the level that we can offer now with intravenous thrombolysis and mechanical thrombectomy. And finally, sadly, primary prevention and recovery science in stroke are really rudimentary. This is the current state of the field. To reflect on where we are right now, I wanted to highlight to you several important advances in stroke highlighted by the Lancet Neurology Journal in 2020. And what I encourage you to pay attention to is the incremental nature of our advances. These are important advances, there is no question about it. But are they groundbreaking? Are they innovating? Are they forging new paths? Are they opening opportunities for new approaches in stroke diagnosis, treatment, and prevention? So one of the advances highlighted is a Treat Stroke to Target initiative that has been presented by our colleagues who compared use of statin in secondary stroke prevention and clear benefit of precise to goal lowering of the statins after stroke and secondary stroke prevention, as opposed to relaxing the window for LDL goal. So we know that statins are incredibly potent for secondary stroke prevention and other progression of atherosclerotic disease. And here we have a confirmation that treating to target is beneficial, but it's still incremental from what we know today. Thales trial of ticagrelor and aspirin in comparison to aspirin alone. We have shown that the dual antiplatelet use, in this case a novel dual combination ticagrelor and aspirin versus aspirin, is beneficial in short-term use post-stroke for stroke recurrence and prevention of stroke recurrence. This is great, but as you can see, the theme continues. It's dual antiplatelets that we've already known in the use of clopidogrel from the trials, CHANCE and POINT trials. And then a very much hoped for trial of a neuroprotective agent, NA1, the trial that is co-authored by Dr. Hill and Dr. Tinyansky from Canada, really a trial that everybody been looking for to see how it will apply in the new era in reperfusion. Unfortunately, had shown no benefit or equipoise rather in the groups that were treated with NA1 and or placebo. So as you can tell, and as I've implied, the advances in stroke in 2020 were rather incremental, important but incremental. And what I'd like to do in the next few minutes is to push our limits of imagination, looking farther, being more innovative, and thinking about new precision-based therapies as well as other approaches in stroke. And why is this the case? Why do we need to push these boundaries? Well, that's because the mechanisms of stroke are much more complicated. It's not only about reperfusion, even though reperfusion is paramount. It's not only the use of antiplatelets or antithrombotics, which is paramount, but it's not just that. we need to be able to dissect the mechanisms. And here we're only talking about the acute ischemia. I'm not even going to be able to touch on a variety of the pathological mechanisms that underlie intracranial hemorrhage as well as subarachnoid hemorrhages. But there are so many pathways that have been initially explored, then given up on, and then potentially will need to be explored in a different context with the different methodologies and creating a different landscape of the future stroke strategies. So let's talk about diagnosis first. You have probably participated in any type of diagnostic activity on stroke on a daily basis for many years of your practice in the past few years. What you really are doing when you're seeing the patients at the scanner or trying to understand the etiology of their disease is you're really classifying stroke subtypes on a daily basis. And some of the very creative colleagues of ours, they have been thinking about how to dial up a notch our understanding of etiologic stroke subtypes. Why is it important? Because obviously, if we know whether the stroke is a small vessel disease related or related to large vessel atherosclerosis or cardioembolism, then we can tailor our stroke prevention strategies and hopefully be able to, in the future, affect the recovery mechanisms should we develop the understanding with regard to the mechanisms that underlie them. So I would like to show you an example of a simple, so to speak, reclassification mechanism. And this is the work by our colleagues at Cornell. Dr. Human Kamel and his colleagues have looked at the proportion of ischemic stroke etiological subtypes when you start considering very specific characteristics that may be sufficient for defining particular stroke. But they took their work further and they actually have used a machine learning algorithm to predict stroke mechanism in a particular subtype of interest that you've all heard about, the ESA stroke subtype, the embolic stroke of undetermined source. So as you know, many patients, almost a quarter of them, often present without an indication of their original source of stroke, an etiologic subtype. In those strokes that don't have an identified origin and they have embolic features, those strokes for the past decade or so have been referred to as ESAs, embolic stroke of undetermined source. And Dr. Kamel and his collaborators have developed a machine learning algorithm that's recently been published in Journal of Stroke. And that algorithm is being trained on, so to speak, gold standard identification, the strokes of known etiology here on the left, and then use the artificial network, neural networks or machine learning algorithm that then were able to predict strokes or apply to strokes of unknown etiology, and predicted that 44% of those strokes were actually of cardioembolic source. I'll tell you a little bit more about it. They have used the machine learning classifiers that were able to distinguish cardioembolic versus non-cardioembolic stroke with excellent accuracy. And you could see the area of under the curve is 0.85, which is a really good precision with which these types of strokes were differentiated when you train the algorithm on the gold standards. And then they characterized those ESAS patients and were able to state that those patients with high predicted probability of cardioembolism were older, had more coronary and peripheral vascular disease, lower ejection fraction on their echocardiograms, larger left atria, lower blood pressure, and higher creatinine levels. So these characteristics, which we now know may potentially increase the risk of an ESAS, otherwise an unknown source stroke, being cardioembolic, are really helpful for us to understand how this machine learning neural network really learned to identify these strokes and verified it in a prospective fashion. So this is something that, as a researcher, I'm really excited to see, because I can tell that some of the questions that we're struggling with on a daily basis could be really addressed by applying creative methodological solutions, and in this case, machine learning algorithms that are learning from the experts, such as vascular neurologists, using all available information for characterizing these strokes. And hopefully in the future, this type of algorithms may be available at our fingertips, maybe even in the emergency room when we're making decisions with regard to patient destination in terms of admission and particular hyper acute treatment strategies related to a precise stroke diagnosis. So could this be the future of stroke diagnosis? Stay tuned for that. The next item I'd like to address is precision-driven therapeutics. And as an example of the therapeutic advances here, I would like to present to you some of the very basic work recently published by our colleagues at UCLA, at the Hinman Lab at UCLA, that used really the very latest to answer some of the crucial questions related to the coronavirus infection and association with increased rate of cerebrovascular events. As you know, there's been a lot of reporting with regard to cerebrovascular events in association with SARS-CoV-2 infection. There have been some controversies. There have been some potentially reflections on the trends throughout the course of the pandemic. But regardless of any specific statistic applied to any particular stroke population, we know that there is a vascular affinity by this new coronavirus, and this vascular affinity is potentially has a potential to affect cerebral vasculature directly. So Dr. Kaneko in Dr. Hinman's lab worked to develop a 3D endothelialized MCA model. They really used a 3D printer to create the model of middle cerebral artery. And they've tested the association between the hemodynamic stress and expression of the ACE2 receptors. As you probably have heard, angiotensin converting enzyme 2 receptors have been implicated in the pathophysiology of COVID-19 virus entering the cells. There have, however, not been any evidence with regard to direct effect on brain endothelium. And so what I'd like to show you, and in this particular slide, I'd like you to pay attention to the graph bars presented here that reflect the folds of expression of the ACE2 receptor in different tissues that they have tested. And as a premise, the ACE2 mRNA levels are low in human brain and monolayer endothelial cell cultures. However, when this model that the Hinman lab built, when the model had experienced increase in the vessel size and flow rates, which is very interesting and important, there was an increase in ACE2 gene expression and protein levels progressively. And you could see that here as the size of the vessel is increasing from 2 millimeters to 3 to 4, and the flow rate is increasing. The expression of these genes or mRNA of the gene is really increasing. And what was interesting also is that the COVID-19 or SARS-CoV-2 S protein, the liposomes that contain that protein, were also detected in the human umbilical cord endothelial cells and human brain endothelial cells in the 3D models of the middle cerebral artery, but not in a monolayer culture, which is a control culture. And that was also related to the flow dependent, to the flow in the vessel. And I can tell you that this is very important and directly related to the future of stroke, because this is an example, a classic example of how a very elegant science of understanding gene expression can take us to the next level of developing therapeutics. Just think about it. If we are able to block the production of let's say, mRNA or activation of the ACE2 receptor. If we're able to somehow alter the flow in the human brain culture, then we in the human microvasculature to prevent the exposure of the endothelium to the infective particles, then we can actually potentially prevent the damage to the cerebrovascular endothelium and prevent future strokes that are related to, let's say, to COVID-19 and other infections. So this is just an example, but it's a critical example, and I thought it was a very elegant example of where the therapeutics can take us in the future. Speaking of the stroke recovery, it's another area where we need to realize that the strides of developing recoveries in stroke are extremely slow. Cinemet has been tried in gait recovery, and gamma aminobutyric acid A antagonist has been tried as well. No benefits. Maraviroc, one of the CC chemokine receptor 5 viral knockdown receptor knockdowns, has had some promising findings in the translational models and currently pending human trials. So that's another agent that may be hopeful, but so far we have no data on that. And then, of course, stem cells, as you've all probably been exposed to some of the data to stem cells used in stroke recovery, has been touted as very promising. We've had some promising preclinical and single-arm small human studies. However, last year, a couple of trials, a recover stroke that used intracarotid infusion of the ALD-401 stem cells has not shown really any difference as compared to control or marrow-based cells. And in the PISIS-2 trial, the trial that uses intracerebral stem cell implant recipients, only 1 in 23 recipients with severe arm deficit has met 7 months improvement criteria, so also very disappointing. So recovery is a process, and outcome is a result, and we are having a difficult time predicting outcome. And I'll give you an example. How many times when you are examining patient in an acute setting, and first and foremost, we're having a difficult time looking at an individual with a particular NIH stroke scale and certain vascular risk profile, age, etc. We're having a hard time even predicting what their ultimate injury may look like. These are the two patients who have exactly matching stroke severity, vascular risk profile, presentation, etc. And one of them will have a very minimal damage, while other will have a total wipeout of an MCA territory. And furthermore, we're having even more of a difficult time predicting who is going to walk out of the hospital and who is going to actually have a very severe functional outcome or potentially death. And so starting with this difficulty with prediction, we are not surprised that the recovery as a process is very difficult to address. But how do we go forward, and where do we start building on the foundations of what I call the brain resilience, or being able to withstand the effects of ischemia? And I think this is where we need to start kind of honing down and getting down to the microscopic level of understanding what is going on at the level of the interface between the brain and the vasculature in that prodigal neurovascular unit, which I think in stroke, particularly in ischemic stroke, is really the point of failure. Cells, including the neurons, as well as the supporting cells, pericytes and glia, and in the vascular cells or in the endothelial cells, the creating blood barrier, the target for future treatments as well as the recovery agents, because frankly that constitutes the scaffolding of the brain. And the response during the acute stroke and during the recovery period is heavily dependent on on the health of each individual item in this particular unit. We know about the small vasculature from the days of microscopic examinations of the brain. Again, I bring up the example of Dr. Simler Fisher, who spent countless hours slicing the walls of the small vasculature, describing the lacunar stroke subtypes. And of course, now we are able to see the small vessels using the 7T technology. Here you see the 7T MRI, which is not even contrast enhanced. You can see the vasculature with such precision, which of course Dr. Fisher would have appreciated, rather than spending hours and hours trying to understand the lipohyalinosis of each individual vessel. And we all know that the small vasculature is really the foundation of the brain health as a concept, and there are multiple manifestations of that. And so here I just wanted to present a very brief outline of the types of the small vessel diseases, including the white matter hyperintensity and lacunar strokes, perivascular spaces that may be dilated, microbleeds, and microinfarcts. And we do not need, in this day and age, to provide, or to construct, the thematic research to prove the role of white matter hyperintensity in risk of stroke. It certainly had been shown over the years in multiple cohort studies across the world, including the Framingham Heart Study. Atherosclerosis risk is in community, which is obviously is very well familiar to you, based here in Houston area, as well as across the United States, in a Rotterdam scan study, etc. So we know that presence and severity of white matter hyperintensity is associated with the risk of cognitive decline, dementia, impaired gait, falls, late life depression, incontinence, and of course risk of stroke and ICH. And then in the patients with stroke, is white matter hyperintensity burden is associated with complications after IV TPA and intraarterial therapy, early deterioration after stroke, poor functional outcomes, post-stroke cognitive impairment, recurrent stroke, cardiovascular events, and mortality. So white matter hyperintensity burden is not a silent bystander that you could see on MRI. It's really a sign of a bad brain that does not have the capacity to withstand the effects of acute ischemia or intracranial hemorrhage, or have the capacity to rebuild and restructure after the infarct or ICH in order to attain positive functional outcome. And really the smallest vessel is the common final pathway in cerebrovascular disease. But what we're seeing is that the vessel effect on the white matter fibers is something that goes beyond the appreciable by a naked eye. I just wanted to quickly highlight the work of our faculty at Mass General Hospital, someone I work with closely, Dr. Etherton, who published on the integrity of normal appearing white matter in association with functional outcome after stroke. And he's been able to show that if we look beyond the white matter hyperintensity appreciable on regular, let's say, FLAIR, T2 FLAIR scan, and we look at the microstructural integrity of white matter as reflected in the diffusion tensor imaging characteristics such as fractional anisotropy, mean diffusivity, radial diffusivity, or axial diffusivity, he had shown that decrease in integrity of white matter as seen on DTI is associated with worse functional outcome, even if you look at what appears to be a normal white matter on the scan. So, which implies that white matter injury in patients with stroke can be measured using the advanced microstructural analysis and is responsible or possibly responsible or additively responsible for poor functional outcomes. We also know that between the association of the small vessel and white matter, we also know that if the white matter is damaged, the functional connectivity or ability of the parts of the brain to communicate with each other as the brain recovers after a stroke is impaired. And that is shown in the study by Eric Katina and Marcus Schormer in my laboratory, showing that if you count the measures of functional connectivity, if you account for them in the modeling of functional outcome, you actually have a better prediction, meaning that parts of the brain disconnected through the white matter disease are not adding up to the positive or expected functional outcome, and so white matter disease contributes to the poor functional outcome in patients with ischemic stroke. So what makes me believe is that white matter hyperintensity not only a marker and manifestation of cerebral vasculature disease, but also a pathologic process that disrupts structural and functional connectivity in the brain and compromising early and long-term recovery after stroke. But there are many more factors that contribute to recovery. White matter, of course, is one of the important ones, giving the foundations of structural and functional connectivity. But there are so many other factors that we really need to be addressing in order for us to understand the mechanisms of recovery and the steps of predicting outcome, and also through that targeting some of the potential molecular and structural elements that can then, when addressed in advance, not only prevent a secondary stroke, but potentially can be used in primary prevention. There's things, however, we know and things we don't know, and that black box of what we don't know yet is to be discovered through some of the advanced research methods that we're currently exercising. And those are the methods that you can only do on a large global scale. And I'm going to show you very quickly some of the work that we have done in collaboration with 23 international sites through our study that's called MRI-GENetics Interface Exploration, or MRI-GENIE study. This is really a study that has been put together to explore for the first time the interface between the imaging of patients with stroke and genetic characteristics. Again, you will ask me, what do genetics have to do with current management or diagnosis of stroke patients? And I will say that 50 years ago, we did not know what some of the current mechanisms would be, and or current methods that we'll be using to treat our patients. Statins certainly were not in the pictures when Dr. Fisher was looking at the lipohyalinosis. But if you understand that the foundation of small vessel disease is lipohyalinosis, a process of arteriosclerosis with lipid accumulation, you can actually target lipid accumulation by developing drugs like statins that halt lipid accumulation in vessel wall and prevent strokes. So I would like to postulate that if we understand the genetic underpinnings of current, let's say, lesions in the brain, whether they're chronic or acute, we can target them. We can target these genes in the future through either, gene editing technology exploding right now, or through some of the mechanisms that help us modulate, pathological processes and prevent deterioration of cerebrovascular disease and ultimately prevent stroke. So in this collaboration, we build automatic methods of analysis of neuroimaging features in patients with stroke, including white matter hyperintensities, as well as mapping the stroke lesions in the brain and trying to identify the combination of lesion size and topography in association with different stroke subtypes and ultimately outcomes. Next step is to use these measures and apply them to genetic associations or genetic analysis, in genetic analysis for looking for genetic associations, and is still in the process of being developed. But I hope that the further we get in understanding of what the mechanisms of stroke may look like, the more we advance the future of stroke treatments, diagnosis, and prevention. And so how do we go from outcome prediction to primary stroke prevention? In the next few minutes, I will show you the outline of the discovery project as a process that's been proposed to forge some of the primary stroke prevention measures in the future, and obviously the outcomes of stroke as related to cognitive impairment and dementia. And as I mentioned before, discovery is a study that's a collaboration between 30 clinical performance sites and scientific leadership within the course. Discovery stands for Determinants of Incident Stroke, Cognitive Outcomes, and Vascular Effects on Recovery. You could find us on the web, www.discoverystudy.org. We are a collection of scientists who would like to elucidate mechanisms of brain resilience and susceptibility to post-stroke cognitive impairment and dementia. We're targeting to enroll 8,000 ischemic stroke, intracranial hemorrhage, and aneurysmal subarachnoid hemorrhage patients over the course of the next 5 years. And we will study these patients to understand their recovery process, including cognitive and functional. And we will use a number of research tools, including MRI, PET, fluid biomarkers, genetics, epigenomics, and machine learning. We are addressing a hypothesis that a stroke event in a vulnerable brain precipitates cascading pathological events, ultimately leading to a post-stroke cognitive impairment and dementia. And the overarching goals of discovery is really to determine which specific stroke subtypes can cause or not cause post-stroke cognitive impairment, and what other demographic, clinical factors or comorbidities synergize with acute stroke to result or prevent post-stroke cognitive impairment and dementia. And we will also plan, as a scientific objective of this study, to elucidate mechanisms of brain resilience and susceptibility to post-stroke cognitive impairment and dementia in diverse U.S. population based on a complex interplay between the life course exposure to multiple vascular risk factors, overall burden of pre-existing small vessel disease, and also Alzheimer's pathology, mediating effect of genetic variation, and also effect of strategic acute stroke lesions. So these are all the factors that we are going to be considering and testing in discovery. And this is just quickly the schema of the study, which implies that the patients, all 8,000 of them, will be enrolled while they're admitted for their hospital stay for their stroke. The baseline visit is really very simple. Once the patients qualify for the enrollment, we will collect their clinical data. Most of it is standard of care, including some of the baseline cognitive and functional assessment, and a blood sample for DNA and plasma biomarkers. We have scheduled follow-ups, in-person follow-ups at 3 to 6 months and 18 months, during which patients will undergo multiple testing at the different level of research procedures, including Tier 1, which is a short cognitive assessments and additional blood draw if necessary. Tier 2 includes standardized MRI and DNA for blood work for DNA methylation, plasma biomarkers. And Tier 3 includes amyloid and PET and amyloid and tau PET for these patients, and extended cognitive battery. Beyond the in-person visits, we also have scheduled phone follow-up visits, including cognitive battery and functional outcome battery at 1 year, 2 year, and annually thereafter, as long as the patients remain in the study. The year one of the study was really the foundational, where we built the infrastructure of the network, and we're currently getting ready for our first enrollment, hoping to come online, so to speak, very soon. Years 2 and 4 are enrollment phase, and years 5 and 6 is a closeout. And we really are hoping that our colleagues at the different clinical performance sites, and again, to outline and highlight the role of Houston Methodist as a participant in the highest level of the research procedure in Tier 3. This is really important collaboration. We're hoping that the foundations of the understanding of post-stroke cognitive and functional impairment will help us develop approaches not only to recovery, but also to stroke prevention. Discovery is really the NIH mandate, and we are going to be focusing on that for the next 5 years with zest and enthusiasm, because this knowledge and these data are much needed, and we hope that Discovery will help spur the activity in this area and bring much needed breakthroughs for the future investigations, as well as the directly benefiting the patients. And I will conclude by saying that there is an opportunity for us to build scientific discovery into every application at the current level that we consider in diagnosis, treatment, recovery, and prevention. We really truly need to invest into research at every level and aim to enroll every patient into a research study so that we can advance our current state of diagnosis, treatment, recovery, and prevention so that we can meet the future of stroke that we envision. So deep phenotyping, artificial intelligence, including machine learning and other types of artificial intelligence, inclusion of molecular biomarkers, validated use of validated outcome assessments, multiple domains of recovery, multimodal precision tools, and personalized medicine. All of it is within our reach. It's not available yet at the standard of practice, but it doesn't mean that we cannot study this, and it doesn't mean that we cannot dream in order for us to arrive at the future of stroke that we all envision. So I'd like to conclude by thanking my entire team of Team Discovery. On the left, these are the scientific leadership of the study. On the right, these are the PIs of the clinical performance sites. I'm immensely grateful for their contribution. And moreover, I'd like to thank my colleagues and really my big global research laboratory, my collaborators around the world who helped spur a lot of work that we've put in understanding the interface between the small vessel disease, white matter disease, neuroimaging of stroke, genetics. Again, I would like to thank all of you for your attention, and I hope that stroke may be if we put discovery into everyday's advances. And if we think about what the future of stroke can be if research becomes the foundation of our approach to mapping this future. So thank you. I hope you have a great day. And while I'm not able to take any of your questions right now, I feel free to email me with any questions or reach out to me through the organizers of this symposium. Great thanks. Have a great day.